A lot of emergencies in our world of oncology are just never straightforward. One hemoptysis is not going to look like the next. So I think that people might be kind of hesitant to create a standard way of responding to that because they might think that each emergency is not going to fit the mold of the one prior. But we just need to remember that having these policies and procedures and order sets and algorithms are so important because it's good to just have this knowledge in your back pocket. This is the way we're going to treat this. This is the way to quickly respond to this. And this is the way to treat this in the safest way possible.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, and today we're talking with Cassie Durand, clinical nurse specialist at a regional site of Memorial Sloan-Kettering Cancer Center in Long Island, New York, about developing and applying nursing policies and procedures for oncologic emergencies. This episode is part of a series about oncologic emergencies, and we've provided a link to the previous episodes in the show notes. You can earn free NCPD contact hours after listening to this episode and completing the evaluation we've also linked in the episode notes. Thanks for joining us today, Cassie.
Thanks so much for having me. This is so exciting.
So throughout this episode series we've highlighted the importance of quick identification and response to oncologic emergencies, but ensuring that response is consistent across team members and coordinated throughout a unit or a facility, that's a critical component of emergency management. So to start, can you briefly explain how your workplace has standardized nurses and other healthcare professionals' responses to oncologic emergencies?
Yeah, so originally at MSK, we had our rapid response team. We call it our RRT team. They are a standardized group of multidisciplinary personnel, and they consist mostly of like an attending of the day, LIP coverage, which would be nurse practitioners usually. And then we also have our nursing staff, and then we have respiratory therapists, phlebotomists, anybody who could respond to that emergency. It's a standardized group. And we even have CNS coverage, which is what I am as well. With its success throughout time, the rapid response team, we've kind of created multiple different types of teams for different types of situations.
So along those same lines, as you've referenced, there's different types of teams that you can have. So what are the different types of rapid response teams that you engage for certain oncologic emergencies?
We have our stroke or neuro rapid response team. This crew is our standardized RRT team, but then also we add like a neurology fellow, our CT radiology team. We have a courier that will take the specimens directly from the patient's bedside to the lab, and other members of this team respond to the page specifically to be helpful in the case of an emergent response to a stroke. We also have a cord compression rapid response team. We have a specific team who responds to hemoptysis, which would include like a head and neck fellow, amongst other people. We have a behavioral rapid response team. Each team has people on it with different types of specialties that can be used in that specific event. So depending on what's happening at the bedside, a standardized page goes out to alert those people to come to the bedside.
That's really interesting because you're right. Every oncologic emergency is very different. And so it's not going to be the same solution depending on what the issue is at hand. And so having those attendees be specialized and focused on what the suspected emergency is, that really helps to make sure the right people are there to make sure that response is efficient and coordinated.
Yeah, it's great. Plus, the behavioral rapid response team has like a psychiatrist and a one-to-one. We don't need those people at the hemoptysis rapid response.
That makes perfect sense. And it makes me think about, for those that work maybe in not a cancer hospital, but a general hospital. And so they might have a rapid response team, but is that team prepared and ready to handle what we will see for an oncologic emergency? And so you're right, it's a very different landscape depending on what you're dealing with, and having the right people there with the right mindset is important. So to help facilitate that, certainly we use orders. What types of order sets does your workplace use to respond to oncologic emergencies?
So the first one that comes to mind is probably our sepsis order set. This one was put together years ago when sepsis was really starting to gain awareness and the importance of treating sepsis early was becoming so abundantly clear. What's really great that we have here is to guide our nursing staff. Our vital signs flow sheet combined with our nursing assessment note can generate a sepsis alert. So from there, the nurse can alert the team to enter the sepsis order set. This would consist of cultures, your standard labs, a lactic acid, chest x-ray, normal saline bolus, vitals, vital signs at standardized intervals, and then, of course, antibiotics. We have a tumor lysis syndrome order set, which is a huge oncologic emergency that we see here at MSK. This would consist of your basic metabolic panel, a phosphorus, ionized calcium, uric acid, magnesium, lactate, dehydrogenase. These are all labs that we need to draw like very, very quickly when we suspect tumor lysis syndrome. We have more order sets. We have like a hypersensitivity order set. This one's really more like medication based. So this order set is standardized and the nurses have the autonomy to use it in the case that their patients have a reaction in one of our infusion units. So the nurses use an algorithm basically that they pretty much have memorized at this point in our infusion areas that allow for them to manage a hypersensitivity reaction. So this could be anything from steroids to even like epi, depending on if the patient's showing any signs of anaphylaxis.
I think you've brought up some really important points. Just the nature of having order sets to guide kind of the workflow that needs to happen when certain triggers are met, I think is critically important, right? Because it facilitates like that efficiency of not having to call and wait and ask for orders and all of that. That's one of the benefits, I would say, of electronic health records, of being able to automate some of that based on the information that's being input. Certainly not always easy because the health records get hard to change and maneuver the larger they get. But I think that's a great use of that tool. Then you also mentioned, I think, what's important of that autonomy of nursing to build in best practice, build in evidence-based practice to say, if as a nurse, it's within my scope to assess and identify these symptoms, these triggers, and then the order set and the algorithms that have been reviewed and, of course, appropriately signed off by whatever leadership structure needs to have that sign off, but to really, again, empower that nurse to be at the point of care to say, I see what I see, this is a problem, and I have the autonomy to act upon that with the guidance from those algorithms or those order sets. That's critically important.
Yeah, I work out here in our regional site and I cover as the CNS, I cover our infusion area. And, I now have such a greater sense for the autonomy of these nurses who are caring for these patients getting certain infusions. Like they can react in a moment's notice. And so you need to have that algorithm and order set in order to treat the patient so quickly. So it's really, really important.
That's great. You're absolutely right. Not every site that we're treating patients has a fellow or a resident or an attending physician right there at the elbow. So it's important to have those tools and set those nurses up for success and for high quality care by giving them the tools that they need. So that's a great point. Along those lines of just, assessing the work that you're doing, do you have any metrics that your workplace follows to watch for certain indicators or to measure certain outcomes based on implementing these tools to help manage oncologic emergencies?
Yes, we love metrics. It's like our bread and butter.
You can't help it. We love it.
Yeah. We just know that following metrics is so important for tracking our adherence to our standards and most importantly, just really for improving patient outcomes. I used to work in our urgent care center for a number of years. And one of the first metrics that I can think of off the top of my head is our door to CT for strokes in our urgent care center. We started tracking our door to CT time. And our urgent care center is not a public emergency room, but there's no reason that we can't benchmark ourselves against what other emergency rooms are doing. So a while back, we started to use this metric as a huge opportunity for the entire staff to really kind of enhance our patient safety by getting these rule out stroke patients to CT in a timely manner. And when we first implemented it, we would follow the metrics so closely, like day to day, patient to patient. And now we follow them, on a weekly and monthly basis. But they do so well at it. And, following a benchmark and keeping our metrics is really just getting better patient outcomes for strokes. And then another one that we use in urgent care center is our ESI scores. So when we triage our patients in urgent care, we use our emergency severity index, which is like an acuity scale for triaging patients. The lower the number, obviously, the sicker the patient is and the more resources they need. So we always just want to make sure that we're taking these patients back first and triaging them appropriately. And so we follow those metrics really closely to make sure that those patients are getting care in a timely manner. Another one that's important for everywhere in our institution is are antibiotics given after sepsis recognition. We know that every hour that goes by for a septic patient, it can increase their mortality, right? So this metric is huge for us to track to create better outcomes, because if we can recognize sepsis and give antibiotics as soon as possible, we know that we're going to keep people safe.
That's great information of just how, following those metrics can help you understand how you're performing, but then also how you compare to other sites or other similar units. And I really loved you said that maybe there wasn't a benchmark. You can't find the exact thing that you're doing, but find something close. Like even if it's maybe more, like you said, you're not an emergency room, but hey, they've got a metric. Why not benchmark ourselves against that? It's not going to be a bad thing if we're doing as well as them. So I think that's important, because I think a lot of times, especially in ambulatory oncology, we don't feel like we have the benchmarks for our unique situation because we're not inpatient. And so I think that's absolutely great advice of, if you can't find a benchmark, you can't find something that's exactly what you're trying to measure. First of all, measure yourself just to know what your baseline is, but also find something close, find something that you can at least start as a comparison to give you at least some sort of guiding number that you're trying to hit. So that's great. So along the lines of the order sets we've already talked about, a lot of times we'll hear that these things are sort of bundled. So bundles, order sets, or clinical guidelines. What types of these tools do you use to help manage the oncologic emergencies at your site?
The first thing that comes to my mind is our CAUTI and our CLABSI bundles for our Foley catheters or central lines. We follow our bundles extremely closely. In fact, they fan out in our nursing assessments. If we click that the patient has a certain type of central line or Foley catheter, they're in our orders. We can see the bundles kind of like are just always around. And we don't use like a CAUTI or CLABSI bundle in an emergency, but we actually use them to avoid an oncological emergency. We know that our patients are so susceptible to sepsis. A lot of these patients are getting these treatments that can bring their ANC down to zero. Obviously, having a central line or a Foley can be very kind of like dangerous to a patient, but obviously super important that they need it. So we follow our bundles so closely to kind of like avoid sepsis, avoid a situation where a patient gets super sick. We actually even teach these bundles. We talk about these bundles and teach them to our new nursing staff in our Department of Nursing orientation. So our new nurses are hearing about these bundles before they even really start in their role technically, because we just want to keep these patients safe. And if a Foley is totally necessary, we'll obviously use it, but we just want to know exactly what steps can we take to avoid a CAUTI.
Yeah, I really like how sometimes it's not what it's doing to treat something, and sometimes it's best practices to avoid a complication. So you're right that, there can be various situations. Adhering to a bundle can benefit not only just by treating the issue, but avoiding any further complications along the line. You mentioned new nurses, new orientees getting kind of exposed to those bundles from the very beginning. And I think that's great. Just make it part of their worldview of how to work in this institution. Like, this is what we do. This is what we have to use. What about simulations? Do you use simulations to help nurses prepare to respond to oncologic emergencies?
As part of our nursing professional development specialist team, there's actually a couple, we call them MPDSs. There's actually a couple MPDSs that are solely dedicated to simulations. Their team rotates kind of all throughout the hospital and even comes to our regional area, which is like a ways away from our main campus. They come on a standardized basis. I believe they come out here 4 times a year. And before they come, we meet a ton so that myself as the CNS and our MPDS out here, our nurse leader out here, we all combine thoughts to figure out what the most relevant simulation would be for nurses in specific areas out here. The scenarios are very, very real life mannequins. They're like life size, they breathe, they talk, they have IV access, and they portray kind of like what we want them to. We load up the mannequin software before they come here. In our infusion unit, we'll have the mannequin portray a hypersensitivity reaction. And then all of a sudden they'll be in, respiratory stress, and they may or may not code, or just to keep these nurses on their toes. They really, really enjoy simulation because all the kind of preparation that goes into it on our end before it's so relevant to their area. So the nurses really like it because it's not just like something kind of like random. We also, after that, hold a structured informal debrief, just as we do in real life after the simulation, so that we can kind of like go around, ask questions, what went well, what didn't, what can we change in the future, sim has become such a huge aspect of our nursing education here, and people really, really like it.
That sounds like amazing tools to use, whether it's for student nurses, new nurses, or even, as you said, as like a routine annual competency. I love how you describe the perfect scenario of going to the actual site, looking at that collection of team members and that are on staff to say, okay, what do these people need? What do these nurses need to improve their practice? Or what are situations that they're struggling with or not having as often and they need to focus on? And so being able to tailor that simulation to really meet the need of the nurses in practice at that site. That's amazing. That's what I think everyone would love to have. So you did briefly mention debriefing. Can you talk a little bit more about debriefing? You talked about how it's important debriefing from simulations, but I'm sure a debrief is helpful when we actually experience an emergency and go through the process of caring for that patient. So can you talk a little bit more about how debriefing sessions can improve the care we provide for oncologic emergencies?
I can. I actually am part of a small team who created our standardized debrief after emergencies at MSK. I could talk about debrief forever. Some number of years ago, we looked into the literature and realized that debriefing is such a huge part of nursing education, nurse retention. We worked on the literature for about a year, and then after that came out with a standardized way, an actual standardized checklist, I should say, that we use. And we also saw in the literature that debrief should be held by a leader amongst the group who's also had formal training in debriefing. So we worked with our nursing education department to create the actual training for the leaders. And there they learned specific aspects of debriefing. And then they also learned how to use our checklists. And then we have a debrief leader hold the debrief after every emergency. Here at MSK, we have a debrief after every code, no matter what. And then we have a debrief after every rapid response that results in an escalation of care. And then we have one as needed if the group just kind of like requests one. What's really great is that we also work with our quality department. So we take these checklists that we use during the debrief sessions, we send them to quality. One of our quality managers takes that and works kind of back full circle again with our nursing professional development specialists to kind of create ways to educate groups of maybe nursing staff or whoever else that was involved in the debrief to educate them on something that they may or may not have missed or something during the event. We have a lot of new staff members on the floor, just like I'm sure every institution has. So I think they really appreciate the debrief because they can really learn so much from it. We call it a hot debrief, which means we're debriefing right after the event. So that way we can get almost every member from the multidisciplinary group to kind of like stay and very quickly and succinctly talk about the event. That way we're not chasing people down kind of like the next day or the next shift to debrief. And I've seen some pretty good results. It's great.
I just want to talk about this for like another 30 minutes because this, of course, we're talking in the realm of oncologic emergencies and that sort of response, that critical response or a code, like you mentioned. But that debriefing is important for any unexpected occurrence that happens, and makes my little CNS heart pitter patter when you send it to quality and then you come back and like you share what has been learned about what went well, what didn't go well is almost more important. Such rich information to learn from every episode that happens, good and bad. If you don't have a mechanism in place to circle that information back around so that everyone can learn from that. And part of it is also just like, I think mentally and emotionally processing the event as well. I mean, that's, I'm sure, a huge piece of debriefing is not just the critical components of the technical skills, but like, how did everybody feel how that went? What could have gone better? What could have gone worse? Hopefully not worse, but, championing things that went well and focusing on that. I think that's just, as you mentioned, sometimes it feels like impossible to do it in the moment, but that's the most important time because you do get everybody who was there versus when they scatter back to their own home departments if they came from other units to help assist. Getting that initial response in the moment so that memories and thoughts are fresh, but then also having a time set aside to go through that more methodically so that information isn't lost, that there's something to be learned and gained from every situation that occurs.
Yeah, the leaders that go to the training, they learn how to really make sure that the people who are involved in the debrief don't feel like it's punitive. That way everybody can kind of gain something from it without being kind of scared to share. And we also, and you brought up a good point about the psychosocial aspects, like a lot of this is very kind of, it's like a lot to handle for some of the stuff that we see. And so we invite social work sometimes or chaplaincy, and that way the nursing staff can feel really supported by everybody.
That's a huge piece, I think, especially for those newer graduates or newer nurses to oncology where, maybe they've not experienced something like this before. So it can, I think, be a lot to take on. And then all the second guessing of, did I do this right? Or could I have done something different? So I think that it's a huge piece to that debrief as well. So it's great to hear that that's part of your process. So you had mentioned that the leaders, they specifically go to training, education for that, which I think is amazing because that's not something that everyone, there's a good way to do a debrief, just like there's information to be learned for any new skill that you're picking up. So are there other types of continuing education that nurses can explore to prepare for oncologic emergencies?
Well, specifically here at MSK, we have a course called Foundations of Oncology, which is for our newer nursing staff members who don't come in with OCN certification. It's a very intensive oncology course, which goes through everything from treatments for like specific diseases to kind of managing onc-emergencies. People really appreciate this when they come here because we are so specific. And so this gives them a real foundation before they get into their practice. We also offer a class here called Managing Oncologic Emergencies, which is obviously very specific and relevant to this. And they cover pretty much like every type of onc-emergencies, sepsis, bleeds, tumor lysis, neuroemergencies, etc. There's a lot more. It's a very robust full day class. It's offered quarterly. Every nursing staff member here is, of course, BLS certified. And then those in their specific areas where it's appropriate, they're ACLS certified. And we also actually keep all of that in-house. So our nursing professional development specialists kind of track that and hold classes when necessary.
Yeah, I think you bring a great point that individual nurses will need to assess what their own needs are for their continuing education. If they work in a generalized community-based practice where they see all types of cancer, then they'll need to have that familiarity with any oncologic emergency. If you work in more subspecialized care, maybe in a more clinic-based setting, then that will kind of change and guide where you should focus your continuing education. So it really is that personalized learning needs assessment to say, okay, what am I likely to see in my setting? So what should I focus my education on versus maybe I won't see it, but I still need to know about it. And so I think that's important for nurses to do that sort of self-assessment to say, well, what's going to be the most helpful for me to improve my practice? So you also mentioned earlier about having that multi-specialty team come for those responses to oncologic emergencies and really catering that team to what the issue at hand seems to be. That brings up the point that we have lots of colleagues in other roles or specialties that could be involved or be part of the experience of an oncologic emergency. So how can colleagues from other roles or specialties, whether that's clinical nurse specialists, as you are, telemetry, resource nurses, how can they support oncology RNs during an oncologic emergency?
Well, I'm glad you asked this because as of a couple of years ago, we now have a clinical nurse specialist that's available 24 hours a day at our main campus site where all of our inpatient beds are, nights, weekends. There's always one there, and they support the nurses and they also respond to emergencies. Our CNSs have such a great rapport with our staff members, and I find that the nursing staff always feel so comfortable now asking them questions or calling them for help, wanting to kind of show them something or like ask them to look up a policy for them. But then also the CNS who's covering in that area will also respond to like an RRT or a code, and they can serve kind of like any role necessary there. So I work on the weekends sometimes, and I can show up to a rapid response or a code, and I can, take specimens to the lab or look up lab values very quickly or grab a med guideline and kind of read it out loud to everybody while they're giving a medication, look up a policy very quickly. We even sometimes as CNSs just facilitate the transfer to the next level of care. And I could even jump in and do CPR. So as the CNS at the bedside, I think that sometimes the nurses, when they see us there, even just like our presence there keeps them kind of like at ease during a critical situation because they know that we can jump in and help when needed and if needed. Our nurses do such a great job in emergencies. But I do think that having people like kind of in our role as a CNS there really just makes them feel so much more comfortable. because they know we're such a big resource to them. We also have our telemetry resource nurses. They come to floors where those floors don't have telemetry, right? So if a patient's on an inpatient bed on a unit that doesn't have telemetry, the telemetry resource nurse will come down and help out and kind of like service the tele nurse until a bed frees up on a different floor. So they're like a huge help too.
This is not intended to be a commercial for a clinical nurse specialist, but I also
But
it might be. You just really made a great case for, I think, the value of clinical nurse specialists to be that resource to nurses, to not their boss, not their, operational management piece, certainly critical, important, but there is something special about having a clinical expert who you feel is a colleague and a peer that you can reach out to, ask those questions. And as you said, in the midst of an emergency, knowing that there's somebody there to support, even if it's just running things, being extra hands, that can make all the difference to feel like you have at least enough people there to manage the situation. I think everyone comes into emergencies with a different mindset. I always joke, like, I'm the one who will be the note taker. I don't function well, like in those emergent situations, but there's still a role for me there, right? I can be the runner. I can help console the family if they're at bedside. Like, there are things that we can all do. And we all have, I think, talents and things that we find easier for us and harder for us, but just know that there is a need for those extra hands and that extra role there. And so great commentary. I love that, everything about that. So
nothing makes me feel better as a CNS than when somebody turns and sees me and says, "Oh God, thank God you're here."
Right. Yes, absolutely. I think there are many sites like Memorial Sloan that has embedded the clinical nurse specialist role as part of the organization. And I think that's wonderful. And not all organizations, not all facilities have clinical nurse specialists, and they embed them in different ways, whether it's unit specific, facility specific, specialty specific. And there's no right or wrong answer to that, I think, but just acknowledging that that's a valuable role for our nurses to have as a colleague, as a mentor, as an expert that's there for them and to help them care for the patient. So that is irreplaceable, I think, selfishly speaking. Well, what a great conversation we've had today. We always like to sort of summarize our episode with some quick fire questions at the end, just to make sure that we leave our listeners with the most important points. So to start that off, what are some common misconceptions about developing, whether it's guiding policies, procedures, order sets, bundles? What are some misconceptions about doing that work for oncologic emergencies?
I know that a lot of emergencies in oncology, in our world of oncology, are just never straightforward. One hemoptysis is not going to look like the next. So I think that people might be kind of hesitant to create a standard way of responding to that because they might think that each emergency is not going to fit the mold of the one prior. But we just need to remember that having these policies and procedures and order sets and algorithms are so important because it's good to just have this knowledge in your back pocket. This is the way we're going to treat this. This is the way to quickly respond to this. And this is the way to treat this in the safest way possible. And I know, like, we spoke about metrics before too. And so the more we adhere to our policy and procedures, the safer we can keep our patients, and we can also watch our metrics with them too. So I just think that they're also so important.
And that's a great point, is that if everyone's doing something a little different, then it's hard to measure how you're doing it all.
Exactly.
What is something about oncologic emergencies that's not often discussed, but you wish people knew more about?
So we have an urgent care center at our institution, and we also have this kind of new program called our symptomatic care clinic. We have one at our regional site where I'm sitting right now, and we have one at every regional site. It's a huge change in our practice here. We're almost like a mini little urgent care center in our symptomatic care clinics, but they're so, so important. We can treat these sick patients closer to their home. It's such a great program. It's kind of like building on itself every year with all the kind of emergencies that we're seeing in our regional sites. I just think it's really important for other institutions to kind of understand how, we know our patients at MSK. We want to treat them. We want to be available to them close to home to treat their kind of emergencies. And so I think it's like an up and coming type of program that's really, really great.
That's so important. And from my experiences, sometimes you don't have anywhere else to send a patient except the emergency room, but that's like probably literally the worst place you could send them. Not because they're not cared for, but it's almost like starting the whole situation over versus, as you mentioned, like, we know our patients very well and we kind of know maybe what the issue is and we want to help direct and sort of focus that. But sometimes that's hard if you only have your health system's large emergency room to send them to for issues that are beyond the scope of truly ambulatory settings. And so that's a great point of like, there really is this need for that in between where we know our patients, we can start with those algorithms or those bundles, or we can kind of start that work up front because we already have all the context of what this patient's treatment has been, what is their diagnosis. Like we can already start from there versus starting from zero for a patient that's unfamiliar in the ER. So that's great to hear. And I think that could be a whole nother podcast we could talk about of creating those sort of urgent symptom management clinics to hopefully either help keep patients out of the emergency room, out of the inpatient setting, if that's appropriate. And as you mentioned, keeping them closer to home when they have a larger distance to travel. So all great things, maybe for another time. So what are some additional training or education opportunities for oncology nurses that they should seek out to better understand how to respond to oncologic emergencies?
I think that people really need to kind of like maintain their skills when it comes to onc emergencies, especially kind of like a code situation. I think ACLS practice, BLS practice is super important. I know we get certified every 2 years, but even as part of my role in urgent care when I worked there as a staff nurse and now as a CNS here out in the regional site, I held and hold mock codes to kind of keep everybody's skills going. Our simulations are a huge help with that as well. Our patients are just so sick and they're getting these crazy intense treatments. And so, especially when their immune system is really, really just so shot from their treatment, or they're like at a huge risk for a bleed from their recent surgery. Some people think that oncology is like a slow burn, but really these emergencies happen so quick. They're very quick in nature and they can be very intense. And so, as nurses, we really need to be able to think on our feet. And I just think the more we practice, the better. The more we can kind of like rapidly assess somebody and quickly treat somebody when they're having this type of oncologic emergency, no matter really what it is. It's so, so important to be able to do that. And that can all be guided by like practice and following our standard processes and kind of just like having the wherewithal to stay calm. And so if it's not so foreign to you, if you have practiced, I think it's just an easier situation for you. So I think practice, practice, practice.
That's perfect. And as you mentioned, mock codes, that's somewhat familiar, but why not mock hypersensitivity reactions or mock chemotherapy spills is another one that I've seen people do. It's like, if you'd only do it when it's happening for real life, it's not going to feel very fresh or very familiar. And it is going to be harder to keep your composure and kind of keep your wits about you if you're someone like me who doesn't respond well to that sort of intense pressure. But with familiarity, with doing it more often, even my own home institution has changed their CPR where we're doing it every quarter where we have to sort of freshen up our skills. It's not the full course, but it's you take a little class, you refresh yourself on the algorithms, you have to demonstrate on a mannequin. And every quarter they're making us do this. And like, I feel way more prepared, at least when it's not happening in front of me. I feel more prepared to do that because I'm practicing those skills. It's becoming more of a muscle memory than just something to reference when something is actually acutely happening in front of you. So I think you're right that simulation and that practicing a mock situation are great tools to help keep yourself fresh and ready to go when these situations occur in real life. Are there any other additional resources for those who want to learn more about whether it's developing like procedures or simulations or, response to oncologic emergencies?
I think there's like a lot of resources out there that people at other institutions can kind of look up and utilize. I know that at ONS, you guys have a managing oncologic emergencies course, but I also just recommend nurses kind of getting their feet wet. I remember being a brand new nurse in our urgent care center, and I was almost like afraid to jump into emergencies. And then once I started to really just help out everybody else in their emergency, I felt so much more comfortable in my own. Code roles are a big deal here at MSK. Code roles are assigned at the beginning of the day. And since the birth of assigning code roles, I think that more nurses are being put into situations where they might have historically kind of maybe avoided, but now they're exposed to so much more. And then they feel better about the next emergency down the line. And then, of course, debrief. I think debrief should be happening everywhere, all the time. Like I said before, I could talk about debrief forever, but it's just such a major resource. There's so much literature out there that says, like, taking a moment to step back after an emergency to talk can make you more mentally and psychologically sound for the next one. And so I just think that if your institution doesn't have a formal debrief or a standardized debrief program, you should really advocate to have one, because I know that's like really, really major, especially for your newer nurses too.
I think that's great. You brought up some great points that there is some sort of didactic learning that can be done, whether it's through, as you mentioned, ONS's information. They have a course. We have a learning library on oncologic emergencies. So there's some basic information. Of course, this podcast series could help backfill some of that information. But a huge component is just getting in there and seeing it happen, whether you're early on and you're just observing, or as you mentioned, kind of setting up some mechanism to sort of force people to have a role and understand how their role functions in that team when those situations are happening. I think reading about it, learning about it is helpful, but nothing can replace actually being part of it and witnessing it. And as you mentioned, then debriefing and learning from it. So even if you weren't part of it, you can still hear what happened, what maybe needs to be improved for next time. And that is still experiential learning that is so valuable, so that everyone can learn from every occurrence and set everyone up for success the next time it happens. So what a great conversation we've had today. Learned so much. I think we've come up with 3 or 4 other topics that we can talk about maybe on another episode. Do you have any final comments to share with our audience today?
Thank you so much for having me. One of my colleagues, Mary Elizabeth, recommended me doing this, and I've actually relearned a lot of stuff myself. Just even talking to you guys, I think this is so great that you guys do this. And also, thanks for having me. And I also just want to thank my nursing leadership, Faye and Wayne, for giving me the opportunity to support me in doing this. So thank you guys.
Well, wonderful. Thanks so much, Cassie, for joining us today. I really appreciate all of your time.
You too. Have a good one.
Thank you. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.